back, everyone. Today we shall be talking about early pregnancy losses and also do a few highlights about what we call recurrent pregnancy loss. So what is an early pregnancy loss? Early pregnancy losses, or what you call abortions or miscarriages, we classify them as loss of a pregnancy before 20 weeks of gestation, or loss of a fetus below 500 grams. However, this definition varies depending on the country, because as here as in Uganda, we classify anything below 28 weeks as a pregnancy loss. So early pregnancy losses, these are the most common complications of a human gestation, affecting about 75% of the couples that are trying to conceive. About 15 to 20% will happen as spontaneous abortions or even ectopic pregnancies, and 5% of these couples will have 2 pregnancy losses, and you'll find that about 1% have 3 or more pregnancy losses, and this is where we classify them as a recurrent pregnancy loss. So early pregnancy loss or recurrent pregnancy loss, it is devastating for both the couples and also the clinicians. So we tend to classify it in 2 groups. For recurrent pregnancy losses, there's what we call the primary recurrent pregnancy loss, where the couple has never had a viable pregnancy, or they have never had a pregnancy they have carried to viability, to term in any sense. And then we also have what we call secondary recurrent pregnancy loss. This is where you find the couple has previously carried a pregnancy to viability, but now they are having recurrent losses. And then there is what we call tertiary recurrent pregnancy loss. This is whereby you find the couple is having some viable gestations they are carrying, but in between they are still having pregnancy losses. So that's how we classify it. What are some of the common features or the common causes? For recurrent pregnancy loss, if a couple comes in and you need to evaluate them as a clinician, we classify the causes according to different categories. We have what we call the anatomical causes. Anatomical, you can say structural. Anything that is involved in carrying the baby. So we have the congenital causes, congenital meaning the woman was born with it, and we also have the acquired causes. So among the congenital causes, we have what we call the Mullerian abnormalities. And these are abnormalities to do with formation of the uterus and can sometimes extend up to the cervix and even the vagina. So among the common abnormalities, we have what we call the uniconnuate uterus or a biconnuate uterus, or there's what we call a uterine septum, where you find the endometrial cavity is divided by a septum in the middle. So this normally results in inadequate space for the growing embryo, and sometimes abnormalities also with implantation. So those are the common abnormalities that we see. Some of these abnormalities usually need surgical intervention for the couple to be able to carry a pregnancy. Then we also have cervical incompetence. This can be both congenital and also acquired. Cervical incompetence means the woman's cervix is weak to carry a pregnancy, and usually this one is characterized by what we call a second trimester abortions. These are pregnancy losses which happen usually 16, 18 weeks, 20 weeks, 22 weeks. So cervical incompetence can be congenital. You could be born with it, or it could be acquired. Some of the common causes of cervical incompetence, which are acquired, forceful dilatation of the cervix. Then we also have trauma. Let's say the woman got a significant cervical tear during maybe a previous delivery, and then it renders the cervix a little bit weak. So those are the anatomical causes. Among the other causes which are acquired, we have what we call uterine synechia, where you find the uterine walls have been scarred, and this leads to a very small endometrial cavity, which makes it very impossible for the baby to implant in there. So those are the anatomical causes. So on top of the anatomical causes, we have also the structural causes. And the common ones we are talking about, fibroids. Not all fibroids will give you early pregnancy losses or recurrent pregnancy losses. But it is these fibroids that are located within the endometrial cavity, what we call the submucosal fibroids, that will tend to give us pregnancy losses, because these either result in inadequate implantation or even placental insufficiency. The placenta is not able to support the baby. Then there is structural decrease of space within the endometrial cavity. Then the other causes are usually what we call adenomyosis. So those are the anatomical causes, as in the structural causes of possible early pregnancy loss or recurrent pregnancy losses. Then also under the classification, we have the infective causes, what we call the infections. The infections we are looking at here are notably the torches, and this includes toxoplasmosis, rubella, herpes simplex, and also syphilis. So these can also contribute to early pregnancy losses. Among the other infections, we have also a simple malaria, especially in our African setting. Malaria can give you early pregnancy loss. So those are the infective agents we look at. So the other causes are genetics. Genetics, this is to do with genes for both the man and the woman. So genetic causes most of the time lead to early pregnancy losses, which most of the case you find they are even below 10 weeks and the pregnancy has come out. So for a couple with suspected genetic causes of miscarriages, usually genetic counseling is advised for them, and we tend to do what we call cardiotyping for both the man and the woman. We can also do cardiotyping on the fetus once it is expelled out. So on top of genetic counseling, there's also what we call PGD. However, this one is usually done with, in cases of IVF, where we do what we call pre-gestational diagnosis or pre-implantation diagnosis. And then there's also what we call amniocentesis, which can sometimes give us a few indicators of the genetic causes. So we have the anatomical, like I said, those are the structural. We have the infections, the common ones. And then we have the genetics, something to do with the genes. Then we have also what we call thrombophilia. This, we already know that pregnancy is already a hypercoagulable state. Hypercoagulable means the risk of blood clotting with pregnancy is usually high because of the blood changes that happen. So thrombophilias, which are usually to do with blood clotting, also tend to increase the risk of pregnancy loss. Then we have what we call the luteal phase defect. Luteal phase, to explain it in simple terms, is usually after pregnancy, there's what we call the corpus luteum. The corpus luteum is part of the shell where the egg was released. So its function is to produce what we call progesterone. This progesterone is the one that supports the pregnancy early on, before the placenta forms. However, if there is a disruption in the production of that progesterone before the actual placenta forms, that pregnancy will be lost. So that's what we call the luteal phase defect. Then we have what we call also the endocrine disorders. The common ones are usually poorly controlled diabetes, cases of hypothyroidism or hyperthyroidism, and usually that is to do with thyroid gland. Then lastly, we have the autoimmune disorders, systemic lupus erythematosus, and then this one is usually associated with presence of what we call the antiphospholipid antibodies, and usually it needs about 3 of the criteria for you to be able to diagnose it. There's what we call thrombosis, forming of small clots, loss of the fetus at 10 weeks or more, and then occurrence of preterm labor, which is usually for pregnancy below 34 weeks. And then we also use the lab tests to diagnose this. And this is detection of the lupus antibodies and cardiolipin. So for a couple that is having early pregnancy losses or recurrent pregnancy losses, these are the lines that you need to be thinking about. Is the cause structural? Is it infective? Is it autoimmune? Is it thrombotic? Or is it endocrine factors causing the pregnancy losses? And then, finally, there's what we call the idiopathic causes. Not all the causes of pregnancy losses are known. Actually, 50% of the causes you will investigate and you can't zero down on what could have caused the miscarriage or the abortion. So, evaluation of a couple with such a problem involves a few steps. A detailed history. You need to know the pattern of the pregnancy losses. How many weeks? Was a fetal heart already present by the time of the pregnancy loss? So that gives us an idea of what could be the causes, because like I've said, the causes are a little bit numerous. Exposure to medications, any known gynecological disorders, presence of fibroids, and all those things. So investigations are tailored to what could be the most probable cause. If it is the fibroids, you're looking at imaging with a scan. If you're looking for uterine abnormalities, you're considering a hysterosalpingogram. And then, obviously, a hormone profile if you're looking at possibility of a luteal phase defect. And then cardiotyping for the couple, in case you're looking at possible genetic causes. So, for immunological causes, aspirin and heparin tend to help. For structural causes, depending on which is the structural cause, sometimes surgical intervention is needed. If it is cervical incompetence, sacrilege, which could also be cervical or intra-abdominal, with supplement or progesterone, can help this couple carry a pregnancy. If it is a luteal phase defect, then luteal support is needed for the couple to be able to carry a pregnancy. If it is an endocrine disorder, if it is diabetes, it will need to be controlled. If it is hypothyroidism, this couple may need thyroxine during pregnancy. So treatment depends on the cause, and definitely not forgetting counseling to this couple, because most of the time we find couples have lost about 7 pregnancies. So a lot of psychological support is needed. Thank you very much.